Thank you guys for coming on today. The first time we brought two guests on at the same time, so we're going to have some fun while also learning some cool stuff. So thanks for coming on today, y'all.
Pleasure. Thank you for having us. An honor.
Awesome. Could you give us a little bit of a background as to kind of where you found your way in sports and how you have grown as a doctor in your career?
Yeah, thank you. So, originally I did medical school in Chicago at Northwestern. And while I was a med student third year, I bumped into the profession that I'm currently in. A guy named Bill Knopp was kind of the preceptor with some residents, and they were talking about sports medicine. I'm like, I thought you had to be orthopedic surgery to do this. And he goes, no, let me tell you about it. And took me under his wing and got my attention from there. So I carried through that with residency. I went to a residency here in Arizona at Mayo Scottsdale. I chose that one in part because the residency director was sports medicine qualified and had her certificate, her subspecialty. And so that's kind of where I followed along, always looking to do this. And then I did my fellowship at Medical College of Wisconsin and had a great experience with those docs there. Those currently, they're the docs I got to work with are the Brewers docs, and then they're currently the Bucks docs, and then of course lots of high schools and colleges and things. So I got to have some really neat experiences through fellowship. And then this is sort of an auspicious week. It just so happens that Arizona Sports Medicine Center, we hit our 20-year mark just September 1st this week. And so we started this practice. Dr. Gary Wazlewski, he's sort of the George Washington of our practice. And then close behind Thomas Jefferson, I guess that would be Doug Friedberg. So we have Doug Friedberg, Gary Wazlewski, and I. We started this practice together with just some shoestrings and some gumption back in 2004. And at the time, it was just three young guys trying to work hard and make a name for ourselves and do a good job. And that has parlayed and translated into a wonderful career with wonderful people and just the most amazing experiences I could have ever hoped or dreamed for, from just seeing wonderful patients that I love seeing every day up to, quite frankly, the highest echelons of sports medicine in Arizona, in the sense that our practice, we've been the providers, the sports medicine providers for the Arizona Diamondbacks, the Phoenix Suns in the past, currently the Diamondbacks and the Cardinals. We've also done the Coyotes. So our practice, we've done all four major sports, as well as spring training with a bunch of other teams and high schools and et cetera. So it's just been a really amazing, wonderful ride.
And I would have to highlight one of the stories that I love hearing your perspective on is the experience in the NBA bubble, because you were one of the docs to get to come down with us. So that was a fun time.
Being the boy in the bubble was amazing. It was interesting. It felt sort of like the Andy Griffith show, walking around in Mayberry. It felt like Mayberry, this little Americana town where every character is an NBA player or associated with it. It was just really interesting, very down to earth players who are just internationally known. We kind of slow their step a little bit as you're passing and looking in the eyes and say, how are you doing today? And it was just a whole different vibe because they had nothing to protect and nothing to show and nothing to prove. We're just all in the bubble having this amazing experience. And so I loved it. And it was fun to just be close with you and with all the other guys and just have that time. It's always hard to be away from family like that, but it was an amazing experience. And quite frankly, in many ways, the pinnacle of my practice. I just look to that and say, look at that, look what we did.
Yeah, that was a fun time. Cam, how about yourself? How did you get to where you are?
Well, I can't say I call myself a bubble boy or John Adams, but I got here. I grew up in Eugene, Oregon, a small college town, and eventually made it up to medical school up in Portland, Oregon, or Oregon Health and Science University. Back in my third year, I got a chance to go back to Eugene and work with the University of Oregon docs, and ended up rubbing elbows with a couple sports med docs down there and finding a cool pathway that I really envisioned myself being in. Later took me out to University of Nevada, Las Vegas program because it was great because it was really an experience where you could work at the university, get a lot of sports medicine coverage, work with the university one-on-one as a resident, basically alongside your fellows, get to work with professional teams. When you had any of the USA basketball come by, when they had football come by, because a lot of those workouts would always happen in Las Vegas, you got a chance to interact. That basically ingratiated me to the staff, and eventually I got lucky enough to go to Cleveland, where I went to a Case Western fellowship, and we got to work with the Browns, and eventually that gave me the opportunity to I speak and endear myself to the program so that when the Cardinals came by and, I had George Washington, John Adams, and Thomas Jefferson come by on the sideline, and I told them, hey, I'm trying to get back out to the West Coast. My wife will kill me if we have to stay out in Cleveland.
And I got to interject. You should have heard his rap. He was Hamilton all day long when we met him.
We got lucky enough to come out here to Scottsdale and join a really great group who had endeared themselves to the community. And I was just very lucky to be able to work alongside these folks. And as Chuck had mentioned, they've been around 20 years now and have done nothing but the best in the Valley. And I'm just happy to be here and be a part of the group. And, I'm really hoping that as we continue to grow, our brand grows, we as professionals grow, that we can again continue to work in these awesome environments like the NBA bubble or any other bubble or shape that comes around in the sports environment.
I hope there's not another chance for a bubble. It was definitely a difficult time. It was a difficult time. And you look back at it and everyone enjoyed it at some level, but just to be a part of what could potentially be a once in a lifetime experience, and probably nothing else will ever compare to it. So we'll find you, Cam, we'll find you your version of the bubble out here. I'm really excited to have the two of you on, because where our paths have crossed is not only just being out here in the Scottsdale area, but also working in professional sports, right? Chuck, when we were working in the NBA together, right, our paths crossed all the time, working on, especially on rehab cases. Cam, likewise, working in private practice, you're the go-to doc out here in Scottsdale for all things non-operative, orthobiologic, and the ASMC group is phenomenal. So anyone that looking for help, please go check out ASMC. They are fantastic. They have some of the best docs in the Valley and in the country with their respective specialties. So relative to non-operative, right, what I want to do is really kind of, let's go broad stroke. We're going to talk what orthobiologics are, and then really hone in on some of the more popular ones that I've commonly used with y'all, but then also maybe some new ones that may be on the horizon too. What is an orthobiologic injection, and how are they fitting within the broad scope of sports medicine?
So good question. So what I typically tell patients is, we talk about different categories of what we can do for an injury, say tendon, joint, ligament, something like that isn't operative, that doesn't require surgery. The prior to orthobiologics, the paradigm would be cortisone, physical therapy, NSAIDs, physical therapy, cortisone, ice, all of that, and then this vast wasteland, and then surgery. And so you'd wash and repeat with cortisone, kind of sometimes damage the cartilage or damage the tendon with too many cortisone injections, and then surgery. And it's not always a salvage. It doesn't always work like we need it. And sometimes people are just stuck. So there's this big gap. And so orthobiologics, in my mind, fills that gap. It gives the middle ground. And Cameron and I are middle ground guys. This is what we do. And so I sort of populate that ground with different branches of orthobiologics. And for me, that is the word I use for the umbrella that encompasses all these things. But I start with PRP, or platelet-rich plasma. And then I talk about PRP plus, and what I mean by that is PRP with alpha-2 macroglobulin. This is a second molecule that we get out of the blood. So it's the same blood draw, but we spin it out twice and sort of dehydrate the plasma and get this alpha-2 macroglobulin that reduces inflammation, helps with some of this immune modulation, and potentially preservation of tissue, which is what we're looking to do with all these orthobiologics. And so PRP plus has been kind of a big, newer version of PRP that I found very useful. And then we get into stem cell. And in my practice, in our practice, I should say, we talk about BMAC, a bone marrow aspirate that we get from basically the back part of your pelvis behind. And then we spin that out and get the cells and get the stem cells from that. And then we also do mesenchymal stem cell, which is typically derived from the subcutaneous, from the fat layer. We do sort of a mini lipo. It's not for cosmetic purposes, but we do a mini lipo and then wash out all the fats because that's an irritant to the joint. We wash all that out and then mince it up and get it sort of micronized or smaller, so we're able to inject that in. And there are dormant stem cells that live in that mesenchymal tissue that can then be active and help with those things that we're trying to do with the inflammation, the immune modulation, and then preservation of cartilage and ligament and tendon tissues. And in some cases, genesis, if we're trying to help a tendon grow. So that's stem cell. And then in our practice, we talk about, there has been, and sometimes there's place for things such as amnion allograft, which is amniotic tissue that's purified and that we can inject. I personally don't call that stem cell because it's broken down. And we'll get into more details of some of these things too. But then there's the other thing with orthobiologics that's newer that we've been doing here recently that's called MVASC, or microvascular tubules. And this is basically the capillary layer from a cadaver, back of the thigh. They remove the skin and the subcutaneous from above. They remove the muscle and the fascia from below, and we get down to just that capillary layer. And that's broken down into the tiny tubules, and those can act as the building blocks for angiogenesis, for bringing blood to tissue to help it to heal. And it also works to stabilize tissues. So weirdly, something like that can help with a joint arthritis. We're not building cartilage, in my opinion, with these micro capillary tubules, but what we're doing is stabilizing a joint and improving the environment of that joint by enriching the synovium, the lining of the joint. So that in our world, that's kind of what we're talking about with orthobiologics. There are other elements that people are doing at home and abroad, things such as exosomes and peptides and other variants and spin-offs of things that exist. So that's kind of the nutshell, I would say.
So that I think I take a very similar approach to explaining things. I think one extra aspect to that, and I think it's very important to mention, is really defining what it means to say stem cell, because I think that's a really easily digestible term for folks. The concept that you're taking something, implanting it, and hopefully revitalizing the area. It's very important to note when you talk about all those that in some scenarios, it's not necessarily rebuilding, regrowing, making you your 18-year-old self, and helping to understand the science and when to utilize them and what has the appropriate course of action, I think is really nice. And Dr. Peterson and I, we talked a lot about if there was a way to create this perfect knee again, then we wouldn't still be doing arthroplasty. We wouldn't still be doing a lot of these surgeries. And saying what is a treatment and what is a cure, and how do these fit into your lifestyle, and what is right for you and your age and your population and what you love, and making that catered to you. And I think understanding that these are a part of a buffet of what you could do, and it's making the right selection for you, for your life, and for your lifestyle. But otherwise, I 100% agree. There's a lot of good stuff out there, and not necessarily every single thing is perfect for every single scenario.
Chuck, there was two other terms that you loosely threw in there when you were describing orthobiologics and where that gray space has come to. And you said NSAIDs and cortisone, which I believe a lot of folks are familiar with both of those. So could you briefly describe the difference between NSAIDs, cortisone, and orthobiologics?
Definitely. Thank you. So NSAIDs, non-steroidal anti-inflammatory drugs, Advil, Aleve, diclofenac, Voltaren, these are some of the common ones that we'll think of. And then the steroidal version would be prednisone or prednisolone, that type of cortisone. So stronger. So these are the medications that we've used for eons, to reduce pain, reduce inflammation. It used to be, 30 years ago, you get hurt and they say, oh, you better use your NSAIDs. You better get on some naproxen because you sprained your ankle. The pendulum has shifted quite a bit there to where we've realized you need some of this to help something repair and to heal it. Your body's trying to heal itself. Stop knocking it down. So these things are used for swelling, for pain, and they're still effective for early or mild things. So that's the whole NSAID side of it. Cortisone, tell people that's kind of a two-edged sword. It works great. It reduces your pain, reduces your inflammation, usually for a period of a couple or a few months. But the other edge of that sword is that it has the potential to degrade soft tissue. And I tell people you get three notches on your belt with cortisone injection for any given body part, whether it's a joint or a tendon. Say the knee, once you've had 3 cortisone injections into your knee in your lifetime, you're potentially beyond that, softening, weakening that cartilage. So we have to be judicious and careful. So it's sort of a special circumstance or a really big reason why we're doing cortisone, or to just initiate treatment, because sometimes you can quite frankly easily, the that was easy button with cortisone. With a one and done, if it solves a problem, they move on, the inflammation's gone, they feel great. Cortisone still has a role. The trouble is if we're trying to manage chronic musculoskeletal injuries or overuse injuries, tendon problems, joint problems, if we're trying to manage it with cortisone, we can be causing problems. And if we're trying to manage it with NSAIDs, it might not be enough, or it might not sort of solve the problem or help them enough. And that's where orthobiologics are entirely different. And in fact, when people do orthobiologic treatments, we say, we need you to stop the anti-inflammatory, the Advil, at least 4 days before we do this. And we need you to not take it for at least a couple of weeks after we do it. Some say a month, some, there are different opinions on that, but we have them restrict NSAIDs. And if anyone has a cortisone injection and PRP at the same time, it's ludicrous, because you're taking ice and fire at the same time. You get lukewarm water, doesn't make any sense. So it's wiser to use them in the right arena, understanding what they do and restricting cortisone, restricting NSAIDs, moving on from that tack once we get into the orthobiologic arena.
I completely agree with that. I think one of the biggest issues we have with cortisone is a little bit to do with our impatience as a society and wanting a quick fix and saying like, well, I'm going to Europe in 3 days, but this has been hurting me for 3 months. What are you going to do for me today? And in understanding that these NSAIDs, these cortisones, yeah, they'll help you, but they're not going to fix your problem. And in fact, they'll make them worse. And their role should be, you have some sort of acute injury, you have an imminent trip, you have your son's wedding, you have some event that you need to feel better for, understanding that you're going to rob Peter to pay Paul, but you need to fix it on the back end. And sometimes it has its place, sometimes it doesn't. I'd like to even take that a bit further. When we look at a lot of these injuries, they're not necessarily inflammatory. We call them injuries, but they're more degenerative a lot of times. And when you're putting in cortisone, you're taking NSAIDs, the hope is to decrease inflammation. And what are we really doing if there's not inflammation in the first place? This is a degenerative process due to some other injury, and all we're doing is providing pain control while withering the tendon further. And thus, you're actually worse off than you were when you came in. And you talk to some of these docs who go in and do the surgeries on these tendons that have been shot up 10, 15, 20 times with cortisone, and you're throwing needles through applesauce because the tendon has worn out and you just truly can't cinch it back down.
Another point to make as far as the role of cortisone is sometimes ideas come full circle. You get on the merry-go-round of life. If somebody's knees, let's say somebody's 90 years old, they're bone on bone. It's just their knee is done. They need a knee replacement. But there's some medical reason why they can't have a knee replacement, either because of general health, say their heart couldn't do it, or maybe they're 600 pounds and the surgeon's unwilling to do it because the knee is going to fail in that circumstance. So some people are stuck with their arthritis and they're stuck with suffering. And if the concern with cortisone is that we're going to damage the cartilage potentially, if there's no cartilage, that horse is out of the barn. So we could do a cortisone injection every 4 to 6 months and help people in a circumstance where they're stuck between a rock and a hard place. So there becomes a role for cortisone with, let's say, end-stage arthritis, where they're just not a candidate, medically speaking, for a knee replacement or a shoulder replacement, or they just don't feel ready yet. They want to keep doing their sport that they shouldn't do when they get a knee replacement. They want to keep doing it. We can buy some time and get them a little older. Sometimes somebody's only 44 and they're like, I'm too young to do that. We can kick the can a little bit with cortisone in that circumstance, or we can sometimes help them with orthobiologics. So there are choices. And then I do want to make one point really quickly here. Cortisone is cheap. Orthobiologics are not. And at this point in America, orthobiologics are not covered by insurance. And that should be understood very quickly. And I tell people that right off the bat. And it's not for everybody. For many folks, they're blessed to the point that they can get the care that they need and want, and that's wonderful. And for others, that's a harder choice, and so we have to be realistic as well. And that's where some of these other treatments can come into play. And that's where we hope, Cameron and I both are, and all of us are hoping that at some point, some of these things become more mainstream to the point that it is a covered benefit so that everybody has the same access to the same excellent care.
I'm glad you brought that point up, Chuck, because there are numerous athletes that will go outside of the country to seek other interventions, maybe for FDA reasons, but maybe also it's more affordable. I'm not entirely sure, right? That's a world I haven't fully understood. But I'm glad you brought that point up. And Cam, I want to come back to a point that you talked about, and Chuck, you also brought up too, and it was the idea around Chuck, you saying, we thought back in the day, 30 years ago, early on that merry-go-round ride, we wanted to get rid of inflammation. Inflammation was the devil. And then we kind of come around and realize, actually probably want a little bit of that. And then Cameron, you said as well, hey, is it inflammation or is it degenerative? Because if we're throwing some sort of anti-inflammatory medication or injection on a problem that's degenerative and not necessarily inflammatory, we're really not addressing the root cause. So I really wanted to double click on this idea of comparison or differential diagnosis of inflammation versus degeneration, and when and why you may or may not want to intervene, because we've learned inflammation is necessary in the healing process.
I suppose when I first addressed this with folks, the number one thing to understand is inflammation is a reaction to some sort of injury or ongoing pathology, and it's your body intentionally trying to provoke healing. That's its way of improving itself. And a byproduct of that is pain, swelling, and what have you. And what our hope was initially with a lot of these medicines is, hey, we can improve the pain and what have you. But to Chuck's point, some of those are very helpful. Now, a lot of times these processes are short-lived, and I think the biggest and best way I can describe it is when you think of a tendon, specifically with tennis elbow. I think is the best way to talk about it, as it was the first and most easily studied thing for PRP. We took a look at these elbows and we said, hey, what's really going on with tennis elbow? And it's a change in your collagen fibers. You have these nice tight collagen fibers all over your body that build up your tendon, good, strong type 1 collagen. And I tell everyone that's like a nice rope, and it creates tension, it creates force, it drives the muscle. But when you have repetitive use, eventually you'll get tendinitis and you'll get inflammation. That's what the itis aspect of that word is. But eventually your body will see you continue this biomechanical force and it will say, well, what is the point of me trying to inflame this if it's going to continue to happen? Eventually that collagen will degrade and it will change. It becomes a type 3 collagen, which is mucousy, not as strong. That rope is eroding, and eventually that can become tears. That's the degenerative aspect of these tendons. And if all we're doing is putting cortisone on it, then we actually further the degradation of the collagen, which exacerbates the point. And if you look at some of these studies, again, specifically on tennis elbow, somebody who gets a steroid injection at tennis elbow actually are worse off at 12-month mark because we put the steroid in. They will have a nice peak around 3 to 6 months and then be worse than they were when they first came in. We're not fixing the process. The process of fixing it is, let's look at our biomechanics. Are we overutilizing? Are we moving differently? And then going on from that, how can we fix this and prevent it from recurring? Now, of course, this isn't a hard and fast rule that didn't address joints per se, but the concept remains similar.
Where would the world of arthritis fit within that continuum of degeneration and inflammation?
I suppose with arthritis, it is a degradative process that involves the ups and downs of inflammation. And what I mean by that is arthritis is quite literally a loss of cartilage. And I always tell people, when people say I'm bone on bone, it's because you've lost the cartilage that separates the two. And in doing so, sometimes you can re-aggravate the underlying bone or synovial tissue and lead to the pain and inflammation that you have when you see your knee is swollen. The hope with cortisone is to take away that inflammation, but the same process holds true, that cortisone will wither the cartilage that you have until you don't have any left. And to that point, you make a decision. Am I done with this knee and I'm on to the arthroplasty, or do I not have a choice and I have to continue onward with injections or physical therapy or what have you? But understanding that this is still a degenerative process and that cortisone injections will further your degradation. And typically when you've gone on that far, the meloxicams, the Celebrex, diclofenac, they're just not doing it for you, especially when you consider those medicines lead to kidney disease, they can lead to compounding your heart disease, it can lead to ulcers and what have you. These aren't medicines that are meant to be taken every day. They're meant to help you for a short period, and then you fix what your underlying issue is.
If you don't mind, I'll take a minute to talk a little bit about arthritis too, to just sort of differentiate a few terms. Sometimes it's confusing for patients to hear the word arthritis, and what does that mean? So there are two main categories. You could even say three main categories of arthritis. So arth, joint, itis, inflammation. There's inflammatory arthritis, like a rheumatologic condition. So the poster child for that would be rheumatoid arthritis. And this is, and that can even be juvenile. You can have a 2-year-old that gets diagnosed with this. Usually they're older when they get it, but there are different forms. And this is basically an autoimmune condition where the body causes inflammation and confuses the joint with a foreign substance. It doesn't recognize it as you anymore. And so it attacks it. And this is the body destroying the joint through inflammation. And so overinflammation, chronically overinflamed joints, the cartilage just rusts out, for lack of a better comparison. It just destroys it. And they end up with degenerative and osteoarthritis, but the core problem is an inflammatory condition. So that's one side of arthritis. The side that we usually deal with in sports medicine is more the degenerative side. There's osteoarthritis, and I often have patients asking me, they say, is this just an age thing? And it's not just to try to make them not feel like they're old. It's to illustrate a point, but I said, well, it's not so much an age thing because I have 18-year-olds with degenerative arthritis. It's an injury thing. Whatever causes the injury causes the arthritis. In this branch, the non-rheumatoid arthritis type. And so time is one variable. Yes, time, your age. Time is a variable that causes cartilage to wear out. We just get wear and tear. I mean, we get gray hair, we get wrinkles, our cartilage wears out. We live our wonderful lives and we have all the great experiences we can. But yeah, we're slowly wearing out after we peak. And so that's one side of it. Time is a variable. Another variable is genetics. We can't measure this very well, but we know that some people have more resilient cartilage than others. Some people have stiffer joints. Some have more flexible joints. Some have longer tendons, shorter tendons. Some jump higher, some are stronger. Our bodies are interesting and different from each other and do different things. And there are definitely some genetic factors that contribute to the longevity of cartilage. And then the number one thing that I mention to people is damage, the key. And this is so important to an arthritis conversation. If we can somehow help young people to not hurt their bodies, not trash their bodies, we can preserve. And then this is where orthobiologics come in, quite frankly. When somebody does have some unfortunate or tragic injury, that's where we can hopefully help them to try to restore or at least preserve. And so I usually, on a podcast, you won't be able to see this, but I use my hand with patients and I say, this with my hand straight, I say, this is the longevity of your knee. You start here and at age 97 and a half, you're there and it just sort of slowly wears out from time. The damage part of it is where you have an injury. So then I bend my hand at the knuckles with my finger straight and go, poof. So the point where my knuckles bend and my fingers go downward, that was injury. And so now there's a slope difference on longevity of my cartilage. Once there's damage, it wears out faster. And that's why an 18-year-old can have arthritis. They have some fracture that goes into the joint. Well, they have arthritis right now. So that's the problem. And things degenerate over time. And then as time compounds that from the date of injury, the farther away you get from the injury, the more of this difference in the slope of the longevity of the joint you'll see. And they'll get this degenerative change. And this is where we have these ideas to try to help people with their current function. But we also have the ideas to try to slow down the degradation. Can we adjust that slope a little bit and curve it back upwards to where we're not necessarily giving them a 16-year-old knee again. We're not necessarily growing back all of their cartilage, but can we slow down that degradatory process that started because of injury, which can come from an acute injury, overuse injury, whatever is contributing to it, that damage. That's what we're trying to achieve with these orthobiologics in particular. And sometimes we'll do it sort of cleanup mode where we're like, whoa, this is a mess. You're in trouble. Let's try to help you. And other times we're doing it preventively. We're trying to see what can we come up with a young person with injury. And I can, I'll use my son with his permission as an example. He's 20 years old. He was a basketball player in high school and unfortunately had a few run-ins, a couple of ACLs, a couple of MCLs, meniscus. And then he also, unfortunately, on one of his knees had an 80% chondral injury from when he tore his ACL and MCL. It was more of a football injury in basketball. Somebody chopped his knee out during a layup. So now we've got a 17-year-old kid with a 80% loss in one spot of his cartilage surface, and you can't bring that back. So what do we do? So about 3 weeks ago, I actually did one of those orthobiologic injections. I did PRP plus alpha-2 macroglobulin into both of his knees, not because we're at the end of the road where we're like, man, how do we salvage this mess? But we're at the beginning of this kid's road of how do I help him to keep doing his fun, active lifestyle as he's into college, but also how do I slow down that degradatory process if possible? And so a lot of the reason why I did this injection is to try to change the slope if possible, because theoretically that's part of what we're talking about. And maybe I don't know for sure that it's going to change it, but as the dad who knows how to do this, I'm going to do it, So that's just one example.
Absolutely, you care about your kid, and more importantly, you know your stuff too. So I'm excited. I'll be following up with you on to see how that process goes, because in such a young, it's not normal to have that large of a chondral lesion at that age. So I'm just really curious where the path takes you in the experiment. Let's just go on an experiment that you're going to end up probably doing over the course of the next 10 to 20 years. So it'll be fun to follow.
That's right.
I think the best way to go, because you guys did such a great job breaking down, highlighting, Chuck, early on, highlighting some examples of some of the orthobiologics, differentiating between what is and what isn't an orthobiologic. Cam touching on degeneration versus inflammation and how they can be happening at the same time, but also maybe at the opposite ends of the continuum too. So I think the best way to go about this is let's double click on specific types of orthobiologics. And then within each one of those orthobiologics, just briefly touching upon how do you determine if you're going to be a good candidate for this, or the likelihood of you having positive outcomes from this type of orthobiologic is going to be an option. Your decision matrix within each of these injections, I think, is the best way to go about this. So to kick it off, let's go with the most popular one that Cameron, you also alluded to, has the most variability into what it actually is, especially in this country, and that is stem cell injections. What stem cell injections are and how can they be used in sports medicine?
Yeah, I think it's a very tricky topic to talk about because you have to be thorough in the way you explain it because there is so much variability on how it's expressed to individuals. And what I mean by that is you'll hear about it in movies, you'll hear about it on the news, you'll hear about it in life. Your buddy down the block just got his first hole-in-one because that doc gave him a stem cell injection and he feels better. You get so many anecdotal ways that it's approached to you and described to you. And I think there's that sci-fi component too, that stem cell rebuilds everything and makes you perfect and pure again. And so when you look at stem cell or the concept of stem cell, I think the first thing to understand is stem cell itself will not necessarily rebuild everything in the most perfect way that it once was, at least not that we understand thus far. When you talk about stem cell, what you're talking about is a product that you're putting in that you're hoping will do that, but in reality is basically taking a semi-differentiated cell, meaning not the perfect cell from when you were in the womb, but taking a semi-differentiated cell and providing that influence in the environment to which you're providing it. So, for example, you can take things such as amnion, you can take micronized fat, which have variability to which they are a pluripotent, meaning it can be various things. That's what it means to be pluripotent. And you put it into the area. And if you take the knee joint as an example, you're hoping that by injecting it in, its nature to want to decide what it will become, you're hoping that it will become purpose. You're hoping that it will become synovium. You're hoping that it will become what you are lacking. And in doing so, improve the environment and improve your pain and improve the influence it has on your life. Now, I think the best understanding of that is in some scenarios, we've seen tendon improve, and it will never be your native tendon. And same with the joint. In some series, you can see that the cartilage will improve. Again, it's not your native cartilage. And to the extent to which they're doing it, we're not always 100% sure. But a lot of the times, depending on the specific quote-unquote stem cell option that you select, it's doing it in different ways. The biggest way that we find we're doing the vast majority of these are providing building blocks or recruiter cells in the hopes that this allows your body to resynthesize that which you're lacking. And I know Chuck also, he describes this in an excellent way. But we both have the same foundational concept that you need to understand. You may never be your perfect self, but our hope in doing all these is we can functionally bring you back to what you want. And that may not necessarily mean that on an MRI, your knee will look perfect, but it may allow you to get back on the court. It may allow you to get back up on the mountain and ski and run and do whatever it is that you desire. Do you agree with that?
Is there a differentiation between the type of stem cells when you're considering injection versus going through an IV and circulating through your system, or are they the same?
Yeah, I think it's interesting. And I'll let Chuck talk on this a lot. I think a lot of it has to do really with the experiences of those around you and your financial means. And I think the biggest thing we're finding a lot of times is people are going abroad to do a lot of these injections. And before I let Chuck delve into this a bit, I think it's important to understand that one of the reasons it can be dangerous to go abroad is they don't necessarily have the regulations that we have here. And it can be a slippery slope. And although some individuals may have had good outcomes, it doesn't necessarily assure you that you'll have the exact same outcome. But otherwise, I'll let Doug kind of take this.
So, it is interesting, the idea of what is a stem cell? What does it mean? What are we doing? Is it infused? Is it injected? Is it ingested? There's all sorts of different ways to look at this. And it can get a little bit wild, wild west in a hurry. And so in some ways, that frontier medicine is where people are traveling to Latin America and South America. That's kind of the frontier of this. And just like there's wonderful opportunity, if you look at U.S. history, there was wonderful opportunity in the frontier. There's also danger. There's rattlesnakes. There's things to be aware of. There's feast or famine. There's drought. So there, just like exploring, it has its inherent excitement and resources, there's also danger. So that's kind of where we are. So the benefit of staying a bit homegrown with some of this, we know the background and the credentials of the people doing it. So I could talk about Cameron up and down and what a well-trained, amazing physician he is. And it's in black and white. This guy knows what he's doing, and he's got this pedigree and this understanding of what he does, and it's very reliable and reputable and reproducible. And I don't mean to speak poorly of anybody else by any means, but I don't necessarily know. There's just mystery with some times where people are going. So we have to be careful of the mystery element of it. They may be perfectly amazing, but if there's unknown or mystery, you may be taking some chances. And then the same thing about the regulatory side of it. It's, in some ways, we are slow. So in medicine, we talk about don't be the first person to do a new procedure, but don't be the millionth person to do it either. There is kind of a sweet spot, just like on a tennis racket. There's a sweet spot in medicine and in orthobiologics where you don't want to be the last person to adapt a new thing, but if you're the first person, you're taking some chances potentially. And then there's also the regulatory side of things and the ethical side of things. Quite frankly, in some countries, their ethics, I'm not going to say are bad. They're just different. And so what is medically ethical is variable. Is there an ultimate truth of what's ethical, or is there simply what's socially acceptable? And every society, every culture, historically and at present, is a little bit different. And so we have to be cautious and careful of that. And there's an element of buyer beware. What are you doing? Where are you going? And what are you achieving? So we have to find the tip of the spear and maybe trying to get something that I need, but at the same time, remain remain true to your own standards for yourself and for your family. So everyone's got to try to weave that a little bit. And when we're staying, so to speak, in our own sphere here, we can have some assurity that we're following that pretty well. We've got our seatbelts on here, we're okay. So it just depends on how many chances you want to take. And quite frankly, there's also, if people use this phrase, there's sort of the sexy side of it. Like, yeah, I went down to Panama and got infused, there's that too. And what does that mean? And interestingly, stem cells, when you look at it, there are different indications for stem cells. So you can treat liver disease with stem cells. You can treat kidney disease with stem cells. You can treat Alzheimer's with stem cells. What are we trying to achieve? And infusion goes into your body and goes everywhere. And so we're affecting everything versus a focused treatment. If I inject stem cells into your tendon that has disease or into your joint that has disease, I'm putting it where it needs to be. So sometimes people are getting these infusions just to feel better generally, or to help with their fatigue generally, or to help with health generally. And some people are trying to find the magic elixir, Ponce de Leon style. We're trying to find the fountain of youth. And well, yeah, we'll go to Panama to find the fountain of youth. Why not? And so some of it is chasing that brass ring of health. That's the side of it as well. So we have to take all of this into account. And I'm not trying to be negative or belittle my colleagues in other countries. By no means am I trying to do that. There's talented, brilliant, wonderful people, and in some ways better access to many things. And there's some buyer beware element of it. And there's also some variability of ethics and variability of cleanliness and product sourcing. And you just have to know what you're doing and be a little bit cautious and thoughtful about these things. Another example, there's Regenikine, for example. There's not just about Panama. Let's take Germany. Regenikine was developed by Dr. Peter Wehling in Germany. And I actually have sat down with Dr. Wehling, and we were together and had dinner together, and we talked about things. And he's actually a very inspiring, dedicated, brilliant individual. And his product, Regenikine, is basically conditioned plasma. So it's similar to PRP in the sense that you're pulling something out of your blood and getting rid of the red blood cells. Then he conditions it and puts it through a process In Germany, they use glass beads to activate different elements of your blood. In the States, Regenekind is done with a resin bead because the FDA won't let us use glass. Glass is safe in Germany, but not in the States. So that shows some variability. But then what I jokingly call it 11 herbs and spices is thrown into there. So there's some proprietary stuff that Dr. Whaling uses to create his Regenekind. But this is where, just historically speaking, this is where Shaq or Kobe have been known to have gone over to Europe, and that's what they did. They went and saw Dr. Whaling. And then, for example, Regenekind came to America, and then Dr. Wazlewski, our partner here, he was the regional person with Regenekind, and there was a lab in our Scottsdale office for that when he was doing Regenekind. So that just historically gives you some ideas, and basically what we're trying to do with these different things is reduce that inflammation, provide longevity, and try to get some healing with whatever we're using. And it's an interesting process of trying to learn globally and also individually. But that shows how not everything is necessarily dangerous. And it just depends on, do you want to fly to Germany and have this done and all of that expense? And can you get it here? And is there something else that works? And a lot of times it's a little bit of trial and error. I hate to put it that way, but it is. It's sort of like trying on a pair of shoes. It's got to fit you right. And just because Adidas is Adam's favorite shoe doesn't mean it's going to fit me the best. Maybe I'm a Brooks guy. Who knows? We just have to try. And then once you do find the thing that works best for you, both financially, intellectually, and then physically, then you can keep at it. Because again, this is a treatment, not a cure in many cases.
Wonderfully said. And I appreciate you calling out Adidas because that is one of my favorite shoe brands, Chuck.
And I've got my Gazelles on today too.
Both did a fantastic job of highlighting different aspects of it. And Chuck, I'm glad you brought up Regenekind because I wanted to bring up Regenekind. And I think maybe we even touched on it enough already, so we can maybe table that. What I heard was folks in other countries are providing the IV for, let's just call, for a lack of better terms, the hope of being that magic elixir, right? If you're not being specific with it and just having it run through the blood, it's not going to hurt, so to speak, and it only could potentially have upsides, right? But then when you talk about the local side of it, hey, let's go in for a particular injection because let's just say someone has a chronic tendinopathy that's preventing them from playing, or they have a chondral lesion that is affecting them from being able to live their life appropriately, maybe go a little bit more focal. So those are, I think, three types of injuries we could kind of consider as saying, hey, someone has tendons, someone has a cartilage injury, someone just wants the magic elixir. And your guys' career, either personally or colleagues, just like over in Germany, what have been the strongest indications for positive outcomes utilizing a variation of reliable stem cell therapy?
I think one thing you need to do first is be upfront and honest about what you're doing with your patients, and helping them to understand what their potential outcomes are. And I know Chuck says this, but I think the concept is brilliant. Understanding curative processes versus treatments, and understanding how whatever it is that we're going to choose to do, whether it's PRP, A2M, amnio, whatever, is this a cure or is this a treatment? And depending on what you're presented with, you need to understand where you fall on that spectrum. So setting expectations is really important. And then I think the second part is patient selection and who you're selecting to do what with. And I suppose what I mean by that is in an older individual or somebody with ongoing active cancer, you may not want to withdraw their own blood and put it somewhere. That may not be the right choice. And then the next thing to understand in terms of patient selection is this individual an athlete? Do they just want to go to Costco and walk around? Do they not need anything special? Are they somebody that's going to commit to their rehab? Because a lot of these times, and I own on this a lot, you have to fix the biomechanics of whatever's going on. If you're not committed to the long-term solution and understanding that a lot of these augments and ways help you reach your goal, but the underlying problem still lives there, then this may not be the right option for you. I think all of those concepts help you decide what is it I'm going to choose. And then the one that Chuck's been very good about explaining is these can be very expensive. And the hardest part about a lot of these is every individual clinic, practice, doctor, whomever is injecting, they can set whatever price they want. And frankly, they will, and they'll use that to advertise. And there are studies that they sometimes have to back that up, but that doesn't mean they're necessarily the right studies or the right way to go about it. So you have to synthesize all that, tell it to patients, and be honest with them, and everything needs to be in the forefront so you can move forward with a good relationship and choosing what's best for them.
And I would add to that, every different body part sort of has its own recipe for success. So like
Yeah.
a knee, for example, I don't hold them back as long for a knee and after an injection with orthobiologics. And they're, quite frankly, their symptoms are less also when they've done that versus a tendon it's a little more intensive and we have to rest them longer and it takes more time. And that is something that requires some PT, quite frankly, to get the job done. It's sort of like a cake. I can put all those ingredients in there. Wonderful. I put in the flour, I put in the eggs, I put in the sugar, I put in the milk. And if you don't put it at 325 for 20 minutes, it's not going to be right. You got to cook that. And the physical therapy and the biomechanics that's cooking the cake. You need more than just the ingredients. And so that's where we need to get your expertise and others' expertise to get that training side of it, the strengthening side of it, the building, the biomechanics, and preventing further injuries through proper motion and care. That's critical for this to work. And so that's where the team concept comes in, where you're gonna have to have a lot of different folks from different backgrounds helping you out to get the job done properly. And I'll do a little personal example. We happen to have my doctor sitting right there with us. He's my physician. He took care of me. I'll use myself as a bit of an example here, if you don't mind. I wanted to do something a little bit more, and so this year I did the St. George half Ironman. And before I started training, all I could run. I mean, I was fine on the bike, but I've got 50 to 60% grade 2 to 3 osteoarthritis of my knees medially from old injuries I had and from life and meniscus and whatever else. And it was to where running a mile or two was a bit of a chore, and my knees really bothered me. They'd swell, they'd hurt, and I just wasn't doing great. So I talked to Cameron, and I also, by the way, had some chronic tennis elbow from picking up my skis wrong, just excited to get out there. And so I was dealing with all this middle-aged nonsense. And so in talking to Cameron, it turned out that we both felt that PRP plus alpha-2 macroglobulin would be my best choice. Number one, because I could treat the joints, and I could also treat the tendons with them. This stuff works to reduce my inflammation, but it also helps with some of that immune modulation and also some of the preservation or tissue genesis aspects. So it kind of hit all the PowerPoints that I wanted to have done. And the nice thing about this PRP alpha-2 macroglobulin is the preparation of it is a larger volume. It can be spread around a little bit easier. So as with one kit and with one blood draw, 120 mil blood draw, I was able to hit all three of those or actually I should say Dr. Davis was able to hit all three of those body parts for me. And I suffered with my elbow for a year with that thing, and it's fine. And what I can tell you as a patient, it actually hurt worse. The elbow hurt worse than the knees did for about a week. It was pretty sore, revved it up. Those cells revved me up pretty good. So I'd move my arm, I kind of smile and chuckle like, oh yeah, the knees were only sore for a couple of days and I got back to training. It wasn't that big of a deal. But I would say the interesting thing, like fast forward at the end of this half Ironman, the parts of my body that didn't hurt was my knees. Everything else kind of hurt. You do this race, you're kind of sore. But I ran across the finish line with a smile and just feeling pretty good. And I'm like, what the heck? I thought the one thing that would keep me from achieving my goal would have been my knees. And that was literally the part of my body that felt the best. It was sort of weird for me to experiencing it as a patient. And so Cameron was able to help me with that. And I got so far over a year's worth of relief from the time I injected it, all that training, doing the race. For me as a patient, that worked great. And it helped me with my knees with the arthritis. It also helped me with the tendon in just different mechanisms, different ways. And I don't mean to make it sound like this magic snake oil that serves all your problems, but I can tell you as a patient, what I experienced was actually fairly remarkable. What Cameron did for me. It was a lot of intensive training that I did, and St. George is known as the hilliest of courses. It's a pretty rigorous one.
The other two that I don't want to say they're controversial, but they're more new in the public market and are talked about quite frequently, and it's just called bro science. A lot of people are talking about them, and that is exosomes and peptides. And those are two I think that fall in the category with stem cells that are kind of more forward, newer. People are talking about them more. Could we briefly touch upon what exosomes are, what peptides are, and do they have a place in sports medicine?
To understand a lot of what these do, but I suppose I'm starting about exosomes is understanding what it is. They're very small transport modulators. They carry items to different cells, such as DNA, mRNA, and what have you, immune modulator cells. And the hope is that by providing a very large volume of these, we can help to improve further improvement at wherever the site of injury is. A lot of times when you have these degenerative processes, these injuries, what have you, we really just have our body to rely on, and I believe it's Chuck who said this to me once. I kind of used it ever since for 12 months now. You could have one contractor at a work site, or you could have 100, and you're going to move a whole heck of a lot faster if you have all 100. And that's the concept about all of these, but especially with exosomes, we're delivering further molecules to you to improve the process, and something that's very similar to that of peptides, except in this scenario, instead of the recruiter cells that we're providing, we're actually providing the foundational block themselves in some scenarios. And in other scenarios, they're also recruiter cells of themselves. So they're both a little bit of a mixed bag, building blocks and recruiting cells.
I love the construction analogy of bringing in more workers and building supplies. So just to clarify, exosomes, we are bringing in more workers to help get the work done, right? To help recruit more of the cells that we want to promote healing, reduce inflammation. And then peptides, we're bringing in more building materials so that way we don't have to make more trips to the store and delay time. Is that what I'm understanding correctly?
I think that's a really good summation of that. To add on, everything Cameron said made sense to me and was good. I would add on a little bit exosomes just to flesh that out a little bit, are sort of like little packets that come from stem cells. So it's the sort of purified action points of a stem cell within an exosome that your body makes. And exosomes are cell transporters. It's like this little car that goes from one cell to another that carries the passengers in it. And so this is a way to try to get stem cell activity, stem cell action points, sort of the concentrated effects of it, the active ingredient, if you will, of a stem cell without all of the other stuff. Like, do you really want the nucleus? Do you really want the whatever else that's in a stem cell? Are there potential interactions that could have? So bringing it down to the active ingredient is what we're talking about. Sort of like, Purell hand sanitizer versus the active ingredient, the alcohol. That's what gets the job done, that cleans your hands. So that's the idea of exosomes. And then peptides, these are the like you said, the building blocks, these foundational elements, these molecules. And other examples of peptides would be things like insulin and human growth hormone and hormones, that our body makes. These are these things that are sort of, they have the ability to initiate something. So that's where peptides are there. So but I think you explained it well, that those are sort of like the workers and the building block.
When you're doing a major reconstructive surgery, whether ACL or a Achilles repair, we considering adding exosomes or peptides into some of these major reconstructive surgeries to promote healing and expedite the healing process, or is that not in clinical practice right now?
I would say all of these things have potential. The ones that are most in clinical practice right now, quite frankly, is just PRP. They act in surgery very frequently. They'll activate PRP. Like for us, we inject it. The surgeons activate it and make sort of a tannish putty out of this yellow clear fluid that we're injecting. They activate it, and the platelets release their contents and make sort of a fibrin clot, and then they actually just plop that onto what they're trying to treat, sometimes sew it right into the tendon. So that's something that's been done for years, over this last decade or more, where platelets are used. People are starting to, in some circumstances, use stem cells or other things intraoperatively, and I do think that that's a bit of a frontier still that we'll get into that more as time goes by.
I think something to also bring up with that is one of the analogies I like to provide with PRP, and Chuck leaned in this, fibrin clot. Think of it a lot like a scab, and what we're inducing with some surgeries and some of these ultrasound guided procedures we do is we're inducing an injury, or we're fixing an injury, and I like to think of it like a scab. And people tend to understand that under that scab is where a lot of that healing can take place. And by inducing these clots, providing these clots intraoperatively, we're creating that additive scab effect where we might also have the injury from the actual surgery.
We've been talking more about what's on the frontier: stem cells, peptides, exosomes, a little bit of regenokine, which is a variation of stem cells from Germany. But I want to pivot here and go to two more prominent orthobiologics that I know both you two are very familiar with. I've seen success in both of these types of injections, them being PRP and BMAC. So really want to have the next part of the conversation talk about where what PRP is, what BMAC is, and then how are they being utilized in clinical practice right now in the world of sports medicine and injury?
So PRP, platelet-rich plasma, that's a blood draw. And in our office, we draw 30 mils of blood, and then from that, get a few mils out, 7 or 8 milliliters potentially. You can concentrate it. But it's your platelets. And within the platelets, we've got factors, vascular endothelial growth factor, and, just lots of different things that can stimulate healing through this cascade. So when we inject platelets into wherever we put it, the platelets eviscerate themselves, put out all these factors and all these signals to try to improve the situation, and then make that rubbery structure as well. And then different from BMAC, which is basically stem cell from your bone marrow. That's concentrated stem cells drawn out of your bone marrow. So it's blood taken from your bones out the back of your pelvis. We do a tap down into there and pull that out, like a bone marrow biopsy equivalent, basically, and then spin that down and use those cells. So in some ways, they look very similar. When you prepare PRP, it looks a little more yellow, and then BMAC stem cell looks more red as far as what it looks like. And then the question is, are they doing the same thing? Are they doing different things? Is one more powerful than the other? And what are the price points? Those are all the things to consider. And this is where there's a little bit of finesse here. The BMAC, it's much more intensive to get it. It's not just a blood draw. We're doing a bone marrow biopsy and pulling it out. So there's more to go through from the patient standpoint. There's also more expense with that, and there inherently would be the difference between a blood draw and a bone marrow biopsy. It's just very different. And so there's the expense thing to where that is 3 or 4 times more expensive to do BMAC than to do PRP. And so you have to justify that cost. The individual would have to justify it. And I tell people all the time, I say, hey, if this is a hardship to you, you shouldn't do it. So it's for somebody that it would be reasonable that that's what their choice would be. So we have to think of the price side of it. And then bone marrow stem cell, is that more powerful than platelets? Maybe so for some things and maybe not for other things. And so there's a lot of uncertainty, quite frankly, and this is the art of medicine. There's uncertainty in medicine. We don't always know everything, so we're just doing the best we can. And Cameron has spoken about this with me before. There's some people come in with an agenda or with their mind made up. Hey, I want stem cells, or hey, I want bone marrow this because my uncle had it, or whatever the reason, and we talk them through that. And if that's their choice, that's fine with me. We can do what makes the most sense to them. And then as far as from our standpoint, though, let's take a professional baseball player with a partially torn ulnar collateral ligament. The team's paying for it. It's not going to hurt the player financially, and we just need to get this kid better. If I'm picking and all variables are equal, for that specific indication, I might go with the BMAC for that ulnar collateral ligament, because maybe there's a little more oomph to it. But I threw the word maybe in there. Other circumstances, I do PRP and also with a professional player and get good results with that too. So I actually don't know the answer, and I don't know if anybody truly does know the answer. We're doing the best we can with some of these things. So there's just some variability there.
I think one of the things people need to understand about orthobiologics is it's as much an art as it is a science. So much of what we do is based on very small sample sizes, very small study sizes. Sometimes the studies are not blinded. Sometimes they've only been done by the manufacturer. And it's taking our background and understanding the research papers and then synthesizing it and applying it to patients who may not be the same patients in that study, and saying how we're going to utilize that. And I think Chuck said it quite gracefully. It's just walking it through with the patient and saying, hey, this is what we got. This is not a perfect science, but based on our understanding and past experience, here's what we're going to do. And I think to expand upon PRP a touch more, because that's something I utilize quite frequently. Chuck and I were talking about, we used to use whole blood when we did some of these injections, because we knew there was something in there that was helping. And so let's just inject all the blood. We know it creates scabs, so let's do that. And then later down the road, we figured out, hey, it's much the plasma and platelets than it is anything else. And so years ago, we started using PRP. And now we've gone from, hey, let's just put PRP in, but let's choose leukocyte-rich and leukocyte-poor. And what does that mean? You're just taking the white blood cells out. And is that important? That's more leukocyte-rich. It's more inflammatory. Leukocyte-poor is more anti-inflammatory. But when do we use that on a joint? When do we use that on a tendon or a ligament or what have you? And now I know Chuck and I are quite fond of alpha-2 macroglobulin is even further synthesizing. And I think we just keep taking these steps and understanding what we have, the science that we have, and applying it to what we think will be best for the patient, whether that's PRP, alpha-2 macroglobulin, or what.
From the PRP, BMAC, stem cell, sounds like there's a lot of different indications, a lot of different variability with it too. And I think the biggest question after, we've broken down all the types of injections, we've broken down some indications for what they may be. It's almost like, what's the hierarchy of where you may want to start if we consider all things equal aside from cost, right? That's probably a really tough question, and neither you ever want to answer it. But from a hierarchy perspective, as far as when we talk about efficacy, we talk about effectiveness. Cameron, you talked about how kind of PRP just slowly keeps advancing and we keep adding things to it, but the principle of taking blood and re-injecting it into a injured area has been beneficial, and then taking stem cells that can potentially help regenerate tissue has been beneficial. The hard question I want to ask is there a hierarchy when we want to consider, hey, I want to go orthobiologics?
I think you asked 100 different doctors and I'll give you 100 different answers. And I think a lot of that is not necessarily just due to practice variability, but it has to do with comfortability with the science. I think Chuck brought up a good point of, the old frontier. Some docs are very fine with early research and being on the forefront and going for it. And other docs are very conservative and they say, hey, listen, PRP is the forerunner, it is the hierarchy, it is the top because it has the most data, it has the most studies, we understand it the best, versus exosomes and peptides, which are oh so new and how reliably do that safely. Versus other docs that say, man, this is the cutting edge stuff, let's do it. Like going to the store and saying, hey, I'm going to go get that new electric BMW iX because it's new and it's fancy and slick, or getting yourself a nice Honda Accord that's been around forever and it's going to go forever. Everyone's going to take a different pick. And I don't know that there is an answer for me. I think there is a way to take a stepwise approach. And to that end, I probably utilize PRP more because I think from a cost to benefit ratio, it is very strong. And that's why I utilize it. But you had said if money was not a decision tree, which a lot of times in reality it is, if you take that out of the equation, it's very difficult to get higher.
And I would say, to kind of build on that, the foundation is PRP, platelet-rich plasma. I would agree with that. It's the one that's the most cost-effective, and it's the one that we can treat all the different things with, and it's got the largest foundation of research, et cetera, even though it's still a little bit murky. And in many ways, though, this comes down to, I take the time to talk with the patients, and I'll tell them, think of me as a computer, and they ask me, what should I do? I say, think of me as a computer. What information you put into me will change what answer I give you. So I need to know how you feel about the financial side of it. I need to know what your objectives are. I need to know what you believe, what your thoughts are, what your research has said. And I need to understand some of these things about them. And so I sometimes give a different answer to every different patient. I'm trying to customize it to them. And then sometimes I will answer just very directly. And I'll kind of say, well, hooked on phonics worked for me. And sometimes I'll mention the PRP A2M because I had such a great response to it personally, understanding that an Adidas foot isn't necessarily a Brooks foot or a Nike foot. So just because I did it doesn't mean it's going to work for you, but man, it worked well for me. So I'll bring that up and then I'll hedge it a little bit. And then sometimes it comes down to the volume. So if somebody has a tiny joint we're trying to inject, maybe PRP plus isn't the first choice because we have a huge volume. We have a big stable. It's 120 mil draw. And so that's a lot. I can't put it all in there. Versus someone like myself where I had 2 knees and an elbow. Man, I got bang for my buck on that because I was able to divide that cost out amongst 3 different joints. And so sometimes it becomes the same PRP A2M, this, if you will, the fancy or the upgraded version ends up being the same price. Had I done 3 PRP kits, it ends up being this, it's a no-brainer because it's the same price. And yet I get PRP and A2M. I get 2 elements in my injection for the same price. And so it kind of depends on all of those different factors and really customizing it to the individual. That's important. I think all of us as practitioners, the best thing that we can do is use these wiggly things on the sides of our heads. We got to use our ears and our hearts. We got to listen to people, be compassionate, and understand where they're coming from to give them the best advice we can.
So I'll encourage the listeners to go over to YouTube to check out the video, because not only has Chuck been so dynamic with all of his illustrations and hands, but he's also wearing a fantastic Hawaiian shirt right now too. So it's just adding a whole nother element to the humor here. So on a more serious note, both Cam and Chuck, you guys did a great job. And I knew that was a very difficult question. I don't think I was going to get a direct answer from either of you, because both of you are pragmatic and critical thinkers and have great experience with both. So I appreciate just highlighting the variability, highlighting the cost effectiveness, highlighting space of a joint versus amount of the draw that you're taking. So thank you for giving that. And I think it gives everybody more clarity as to where you should steer a conversation when people start throwing out names like stem cells, exosomes, PRP, right? Like it just helps to understand that a bit more. Where's the frontier of orthobiologics going?
I'd like to take this one first, because I want Chuck to end the discussion on his dream that he just expressed to me 2 hours ago, which I think is so fascinating, but it would be amazing, because I think it would be truly revolutionary. And we're going to find that some of these in reality don't do anything. Some of these are negligible effects on the overall outcome of the treatment. And some of them we're going to find that some aspects are extremely important and some are not. And the perfect example in this scenario is when we converted from full PRP to A2M. We found that A2M is hyper important. When we can utilize it, it can be beneficial. All that is to say, we're going to distill all this science. We're going to take all these different items and we're going to find the best ones for the best scenarios. And we're going to find some are good for elbows, some are good for Achilles, some are good for joints. And eventually, one day, we're going to find actually how to rebuild some things. How are we going to make this person's bone-on-bone arthritis 20 years old again? How are we going to rebuild this? And I think that's really where it's going to go. I talked to Chuck. There was a fascinating story that came out on NPR a couple weeks ago, maybe a couple months ago. And it was about how there's a group that's working to take peptides, hyaluronic acid, which is a gel, and basically recreate cartilage. And they're currently using it in sheep in the hopes that basically they can build a new knee. Now, of course, that could totally fall apart and we may never advance that science. But I'd like to think eventually we will become better builders and better recreators of injured. And from that, I'll let kind of Chuck add in and express his dream. What I do.
Thank you. So I think what Cameron described is sort of the golden path, sort of that established progression. You just keep walking like the yellow brick road. You keep walking on that path. You're going to get to your destination, and with every step, we're closer to it. So we're going to refine what we've got. We're going to have, look at the research, the cumulative research on PRP, for example, 15 years ago compared to now. It's much better. We know a lot more. That's going to only get better. So if we just keep walking on this road, the cream's going to rise, and we're going to learn more, and there's going to be new things coming in. So I think that the progress along the yellow brick road is going to be good. So the dream is sort of like the city of Oz. Can we get here? So I have actually dreamed about this. So it's not just I have a dream, but I had a dream. These are things that as you're falling asleep in La La Land, your mind just does fun things. So what I would sci-fi wise envision, rather than having to have a knee replacement and an arthroplasty where you basically, it's like a crown on a tooth where they shave off the bone and then put a metal, really fancy, expensive alloyed metal on there with some polymer composite plastic plates in between. And now you've got this knee that works well and your pain's gone, but it's kind of clunky and you shouldn't really run marathons with it. And you're not going to play basketball very well with it, but it takes your pain away. That's sort of the cure, but it's a cure with a cost. You lose a lot, but you're trying to get rid of your pain. So going from that paradigm to a whole new revolutionary paradigm, what if we were to take like a bio 3D printer, like a calcite matrix or something, and instead of metal, have that crown be made out of that? And what if we were to take a matrix from, I don't know if it's from a sheep, let's say that for fun, take a sheep cartilage and get rid of all the cells because we don't need sheep cells in this, but have the scaffolding of that cartilage with all of the collagen in there and apply that, glue that down with stem cells or whatever bio glue that we can get that to stick to that bone, and then grow that in a petri dish and then infiltrate it with my cartilage cells, where you can clone my cartilage cells and grow it in this milieu of stem cells and PRP and peptides and and exosomes and whatever else comes up, and just have this sort of bond and grow. And now we've actually got this beautiful cartilage surface that's infused into the matrix from an allograft to a sheep or whatever, that's bonded to this surface that's been prepared by a computer to fit exactly with that person's knee, how it was when they're 18 years old. And so now the same surgeon, instead of cutting and putting in metal, shaving off the bad, putting in metal, let's have them take off that bad surface and implant this beautifully bioidentical, handcrafted, tailored new knee and pop that on there, then let that grow in. And then the nutrition from cartilage comes from our joint synovium. It doesn't come from blood, so that cartilage can be fed by the person's knee. And then the blood vessels grow into this matrix, this calcite, this 3D printed thing. And now we've got this bioidentical knee that no longer are we saying, sorry, you have a clunky knee that doesn't hurt anymore, but you can't do all this stuff, to, yeah, in 6 months, you'll be ready to do your triathlon or to do your marathon or to get back to skiing, or, give them a young knee back again. That is the, I have a dream. That's the city that's the light on the hill. That's the beautiful sports medicine dream that I hope someday occurs in some of our lifetimes. I think Cameron has a shot at it. I probably don't, but that would be amazing.
That certainly would be amazing. I do believe that would be fun to get to, and also exciting for the industry. And yes, you too would be retired tomorrow if you had the solution to that. So I will do everything in my power to point the people in the right direction for y'all. Fellas, this was amazing. This was a great conversation. It's what I personally needed this in my own wheelhouse, because again, seeing more and more people, access to information is higher these days. People are consuming more information. These terms are being thrown around loosely without real true understanding. And so I found myself having these conversations more with clients, not only athletes, but people that have the financial means to pursue some of these. So this was super helpful for me, and y'all did an amazing job even explaining some of the things that I wasn't even aware of or consideration. So y'all just crushed it. And so I just want to say thank you for taking time on your Fridays, because I know you guys both have crazy busy schedules. But I don't know, Chuck, you're in a Hawaiian shirt. Thank you guys so much. This was fantastic.
Thank you for having us, and flying all the way back from your vacation just to host us.
Yes, thank you for having us.
Man, I got too much color. This is definitely the most tan I've been going down to Cabo. So it was much needed. My wife and I, first vacation in 2 years after her being pregnant and delivering our child. So it was wonderful to be able to enjoy some sunny weather and be ourselves without a child for a short while.
Well deserved. Congratulations on all fronts, and thanks again for having us. It's amazing.